Safety pin, the thick portion or a broken cotton swab or other suitable tool. Occasionally substitute the blunt end for the point. Ask the patient, is it sharp or dull? To prevent transmitting a blood-borne infection, discard the pin or other device safely. Do not rescue it on the other person. Testing the skin temperature is often omitted if the pain sensation is normal. If there are sensory defects, use two test tubes filled with hot and cold water or a tuning fork heated or cooled by running water. Touch the skin and ask the patient to identify hot or cold. With a fine wisp of cotton, touch the skin lightly, avoiding pressure. Ask the patient to respond whenever a touch is felt and to compare one area with another. Avoid testing callous skin, which is normally relatively insensitive. Now the vibration. Use a relatively low pitch tuning fork of 128 Hz. Tap it on heel of your hand and place it firmly over a distal interphalangeal joint for the patient's finger, then over the interphalangeal joint of the big toe. Ask what the patient feels. If you are not sure whether the patient is feeling pressure or vibration, ask the patient to tell when the vibration stops. Grasp the patient's big toe holding by its sides between your thumb and index finger, then pull it away from the other toes. Demonstrate up and down as you move the patient toe clearly upward and downward. Then with the patient's eyes closed, ask the patient to say up or down when moving the large toe. Now the stereognosis refers to the ability to identify an object by feeling it. Place a familiar object such as coin, paper, clip, key, pencil or a cotton ball in the patient's hand and ask the patient to tell you what it is. Normally, a patient will manipulate it skillfully and identify it correctly within 5 seconds. Asking the patient to distinguish heads from tails on a coin is a sensitive test for stereognosis. Now the number identification. If arthritis or other conditions prevent the patient from manipulating an object well enough to identify it, test the ability to identify numbers with the blunt end of a pencil or a pen. Draw a large number in the patient's palm. Now the 2-point discrimination. Using the two ends of an open paper clip or two pins, touch a finger pad in two places simultaneously. Alternate the double stimulus irregularly with one point touch. Be careful not to cause pain. Briefly touch a point on the patient's skin, then ask the patient to open both eyes and point to the place touched. Normally, a person can do it so accurately. Stimulate one side or simultaneously stimulate corresponding areas on both sides of the body. Ask where the patient feels your touch. Normally, both stimuli are felt. Or to squeeze both knees together if the legs reflexes are diminished or absent. Ask the patient to lock fingers and pull one hand against the other. Tell the patient to pull just before you strike the patellar tendon. If the patient reflexes are symmetrically diminished or absent, use reinforcement, a technique involving isometric contraction of other muscles up to 10 seconds that may increase reflex activity. Now the biceps reflex. The patient elbow should be partially flexed and the forearm pronated with palm down. Now the triceps. The patient may be sitting or supine. Flex the patient's arm at the elbow with the palm downward and the body. Pull it slightly across the chest. Strike the triceps tendon. The patient's hand should be rest on the abdomen or the lap with the forearm partly pronated. Strike the radius with the point or the flat edge of the reflex hammer about 1 to 2 inches above the wrist. Now the quadriceps. The patient may be either sitting or lying down as long as the knee is flexed. Briskly tap the patellar tendon just below the patella. Note contraction of the quadriceps with extension at the knee. Placing your hand on the patient's anterior thighs, let you feel this reflex. If the patient is sitting, partially dorsiflex the foot at the ankle. Persuade the patient to relax. Strike the ankle tendon and watch and feel for patellar flexion at the ankle. Also note the spread of relaxation after muscle contraction. If the reflexes seem hyperactive, test for ankle clonus. Support the knee is partially flexed position. With your other hand, dorsiflex the plantar, flex the foot a few minutes while encouraging the patient to relax. Look and feel for rhythmic oscillations between the dorsiflexion and plantar flexion. Normally, the ankle does not react to this stimulus. With a key or wooden end of an applicator stick, stroke the lateral aspect of the sole from the heel to the ball of the foot, curving medially across the ball. Use the lightest stimulus needed to provoke a response but increase firmness if necessary. Closely observe the movement of the big toe, normally plantar flexion.